Acute respiratory failure is never a primary diagnosis. A patient came in with something and then led to respiratory failure. The interesting fact is respiratory failure does not always result from a pulmonary condition. There are several non-pulmonary conditions that lead to acute respiratory failure. There are two forms. You can have hypoxemic or hypercapnic. Hypoxemic means your oxygen levels are low, so that means this is a gas exchange problem. Patient has a condition limiting or impairing the gas exchange part of oxygenation, because there's two parts of oxygenation, right? There's the ventilation part, the act of breathing, inhaling and exhaling. And then there's the actual gas exchange part, which is the diffusion of gases, correct? So there's two parts. You can't have one or the other only. Both have to be normal in order for you to achieve normal oxygenation. So we need to, again, distinguish between acute and chronic, because there is a state of chronic respiratory failure. Only the acute respiratory failure is life-threatening. The chronic one, usually no. Again, there are two forms. There's a hypercapnic and an hypoxemic respiratory failure. If it's hypoxemic, that means we're really referring to an oxygenation failure, whereas the hypercapnic respiratory failure is also called a ventilatory failure. Okay, so when we say, again, hypoxemic, that means the patient has a condition that impairs gas exchange. Give me examples. COPD can be included. Pneumonia is the number one cause. Asthma, cystic. Okay, so you have all of those. No, ALS actually is not a gas exchange problem. It's a ventilatory. Okay? Yeah, but ventilatory. Okay, ventilatory failure. So, or hypercapnic. So let's start with oxygenation again. So oxygenation failure will result from any condition that will impair the actual gas exchange. So you told me some pulmonary causes. Some non-pulmonary causes would include, let's say you aspirated. Okay, so let's say you're drunk, passed out, flat on the floor, and then you aspirated. Nobody saw you, okay, or your friends were also passed out like you, but you vomited and aspirated. Okay, so was that really pulmonary? No, that was GI, right? GI, you aspirated and then you went into respiratory failure. Okay, so it impaired your ability for gas exchange. Okay. So other here are the examples here. So we mentioned COPD, and for ventilatory failure, the others are any condition that will impair the act of breathing, meaning any condition that affects ventilation. So if ventilation rate and depth is affected, meaning you're breathing shallow or you're breathing less than 12 to 20 a minute, that can lead to ventilatory or hypercapnic respiratory failure. Examples are drug overdose. Let's say you overdose on fentanyl. What happens to your respiratory rate? Yeah, you're breathing like 2 a minute, right? So that's hypercapnic. Okay, because are you able to get rid of CO2? No. No, we can only get rid of CO2 if your exhalation and inhalation are normal. If not, then that will raise your CO2 levels. Head trauma, because what happens again to your breathing when you have head trauma? When you have sepsis, what happens to, again, respiratory rate and depth? Same thing for hemorrhage and sleep apnea, right? You have sleep apnea, you sleep like that. Right? That's sleep apnea. Or any other, look, there's so many non-pulmonary problems here. Look at Guillain-Barré syndrome, myasthenia gravis. Are these pulmonary conditions? No, these are neurological problems. Okay? Stroke, ALS, again, these are all neurologic problems leading to respiratory failure. Does that make sense? You get the idea now? So when you say respiratory failure, it's not always pulmonary. Okay, so there's so many causes that leads to it. Because again, there's two types. There's oxygenation and ventilatory failure.
So would all of those like myasthenia gravis and stuff, would that?
Again, anything that will impair the ventilation.
Ventilatory.
Yeah, so meaning anything that will depress your breathing, meaning your rate drops less than 12 per minute, or the depth of your respiration, meaning you're breathing shallow. Look at this example, chest trauma. Let's say you have a pneumothorax. So what happens to your depth? Can you take in a deep breath? No, you'll have shallow breaths, right? Or this one, kyphoscoliosis. So you're bent over and S-shape. Can you have proper chest expansion? No. Or let's say obesity. Let's say, or it doesn't have to be you. Let's say your partner is 500 pounds and they're on top. So can you breathe properly? Okay, so this is what I mean by there's so many non-pulmonary causes that lead to respiratory failure. All right. So let's say a car accident. Okay, you slammed, you're trapped against the steering wheel because you hit the power line, for instance. Okay, a power post. Okay, you got slammed, so you have chest compression. That's chest trauma. All right. Manifestations, all manifestations, there's nothing specific here. So it's just like anyone who has low oxygen and high CO2. Look at the manifestations. Again, nothing specific, nothing exclusive to respiratory failure. However, so since, look at the signs and symptoms, are they any different from any other condition, cardiac? No, right? The same. However, how do we know, how does the doctor diagnose you with respiratory failure? There are three conditions. Okay. We need an ABG, and your ABG will show one of three, usually two out of the three things. Okay. When your PaO2 is less than 60, and your PaO2 is greater than 50, and your pH is less than 7.35. Again, you are in respiratory failure if your ABG shows what? PaO2 less than 60, PaCO2 greater than 50, and your pH is 7.35. In almost every case, all three are present. Because even if it's hypoxemic, let's say, hypoxemic failure, if your oxygen is low, that means your CO2 must be is high, and then vice versa, correct? That means if your CO2 is high, oxygen can't be, oxygen can't be high. That means oxygen is low. And then of course, in both instances, it will drop your pH. Okay. Any question? Okay, so the diagnostic test is ABG. Based on your ABG, if you have these results, then you are in respiratory failure. Now, the easy part of respiratory failure, and just a warning, this chapter is only talking about respiratory failure. Are we clear? What is this chapter talking about? Respiratory failure only. It does not discuss the underlying conditions. Remember, respiratory failure is not a primary diagnosis. Something led to it, right? What are those somethings? All these listed here. And these are not discussed in this chapter. They are discussed elsewhere in the textbook. Are we clear? So when we say management here, this is only management of what? Respiratory failure only. Okay, so when you get to here, this does not talk about the kyphoscoliosis, the trauma, the chest trauma, nothing. Okay, only management of what? Respiratory failure. And what does it say? What's the only management? And no, respiratory, which is how? What do we give the patient? Oxygen.
But what if they don't have the means to contain oxygen?
Okay, that's why we have to discuss airway management and ventilation, mechanical ventilation. Okay. Again, the management of the underlying condition, which is of course part of respiratory failure treatment, because otherwise, will the respiratory failure ever resolve if the underlying condition exists? No, you have to manage those as well, but again, they're not discussed in this chapter. Are we clear? So your responsibilities here is on oxygen therapy. So however we meet that, of course, we start with non-invasive first. Start with cannula, then you go mask, and then you go non-rebreather. The last non-invasive way non-invasive way is
Oxygen.
Deep breathing.
BiPAP. So the BiPAP is, of course, bi-level positive airway pressure
Mhm.
ventilation. So that's the last non-invasive part. After that, we intubate the patient and put them on a ventilator. Are we clear?
Yeah.
And that's discussed on another section. We'll get to that later. Much later, because we have to do ARDS first. So I'll skip the intubation first. I'll come back to that later. Let's go to ARDS. So what is ARDS? Stands for acute respiratory distress syndrome. Now, if you read it, it's actually respiratory failure as well, but a progressive type of respiratory failure. The underlying cause of ARDS is acute lung injury. Now, just like respiratory failure, acute lung injury is not caused, although it says there lung. However, the injury here is actually, most of the causes are outside the lungs itself. Of course, we have two forms of acute lung injury. When we say direct, then that's, of course, affecting the lung. However, there are several indirect lung injuries available. Examples of direct lung injury is what? Chest trauma. What else? Yeah, penetrating or non-penetrating, blunt force trauma.
Yeah.
What else?
Suffocation.
What about the aspiration? You aspirated, tacos and whatever you ate when you were drunk. Okay, you aspirated all those. There's tequila and then there's tacos with guacamole into your lung. What will that do to lung tissue? I mean, the closest, we don't really see lungs in the grocery. We see liver, right? Okay, so imagine, I mean, they don't sell lung in the grocery, right? Yeah, we see liver. So the closest thing you can get to lung tissue is the liver. So imagine liver tissue. If you pour acid on it, what will happen to it? What does fresh liver look like? Very red and squishy, right? Okay, why is it red and squishy?
A lot of blood vessels.
Very vascular. That's why it looks like that. Now imagine a very vascular organ, squishy, and you pour acid into it.
It's gonna turn white?
Oh, okay.
It burns, right? It get burned. Okay, so therefore, right, the problem here is gonna cause a severe inflammatory response. So the pathophysiology of acute lung injury is, let me take you to it. Okay, right here. If you read this, the patient's response to acute lung injury is going to be a severe inflammatory response syndrome, also called SIRS. Remember this in sepsis? We discussed this. Remember the capillaries become very leaky, okay, because of a huge cytokine storm, meaning the severe inflammatory response causes a flood of cytokines into the bloodstream, inflammatory substances, altering the capillary membrane permeability, causing them to be very leaky. Now, because the lungs, again, is red and squishy because there's so many blood vessels in it, so what will happen if each of those capillaries in that organ become very leaky? water will come out, right? Of the blood vessels, of the capillaries. So where will that water go?
Sitting along the body.
No, it's just talking about the lungs first. So where will that water go?
It was stated.
In the alveoli.
Oh,
So
yeah,
now
oh,
the lungs, the alveoli fill with water.
Yeah.
Impossible to happen because can gas exchange occur in a wet lung?
No.
Just like the example with chest tubes, remember the water seal chamber? Yeah. So if you fart in the pool, can the gas come out? Yes, but if you're above, now imagine this is now the pool. The alveoli, 100 million of them, are now like a swimming pool filled with water. Can you fart into that water? No, gas exchange is impossible. Are you following so far? Are you
I follow you.
Okay.
Yeah, I get you, Doctor.
So that's the nature of acute lung injury. So that's why the patient is in ARDS. The lungs are wet because of the acute lung injury. Okay. And what triggered the acute lung injury? We have a long list. Chart 19-2 are the causes of acute lung injury. Take note, there are two types, direct and indirect lung injury. So of course, aspiration, that's direct, right? I mean, you put these toxins, these substances directly into the lung. Pneumonia, that's also direct. Drug ingestion and overdose, is this direct?
No.
This is indirect lung injury. Fat embolism is indirect. Hematologic disorders, you have DIC, remember DIC? DIC also leads to the same acute lung injury.
It was definitely complication.
Yeah. Infection can be local, like here, for instance, you got pneumonia or COVID, or the infection may be systemic. Remember sepsis? Sepsis led to DIC and ARDS, right? So you cannot separate ARDS from DIC. They always go together.
I said that next chapter.
And the rest. Here's sepsis again, shock, trauma. This would of course be, this one is direct and then the others are indirect lung injury. Okay. Any question on how it develops?
Trauma was direct.
Doesn't have to be. Pulmonary condition is direct. However, these here fractures, head injury are indirect, but they're major injuries just the same. So therefore, they still trigger the severe inflammatory response syndrome, okay, leading to increased capillary membrane permeability. Yes, that can also be another one, right, under burns. Yeah, so that's why when we talked about burns, it also leads to ARDS. Okay. So I explained the pathophysiology. Let's go to signs and symptoms. Signs and symptoms, what did I say? This is also a form of respiratory failure, right? Yeah. So this is a progressive type of respiratory failure. So therefore, what's the PaO2?
High.
PaO2.
Low.
Specifically, less than 60. PaCO2 is greater than 50. Greater than 50. And pH is 7.35. Okay. However, since this is a progressive form and you know the nature that the lungs are wet, what happens when you give these patients oxygen? Because what happened to the respiratory failure patient when you gave them oxygen? Did they improve? Yes, they did. They respond to oxygen.
And this is gonna make it worse.
This one, since the lungs are wet,
It's not
do
gonna
they
work.
respond? Okay, so that's why we call it refractory hypoxemia, or hypoxemia that persists despite high FiO2. Even if you give them 100% oxygen, it's not going to improve. Because why again? Why do they? The lungs are wet. I mean, gas exchange is impossible, okay, in a wet lung.
So bedside
Chest tube,
chest
chest
insert,
tube.
chest tube insertion.
No, no, no.
Oh,
Remember,
okay.
chest tube is what are you draining when you put in a chest tube?
Oh,
Where is the
fluid.
chest tube? No, they're
Oh.
fluid, but where is the fluid?
Pleural space.
It's in the pleura. This one, where's the water here? It's in the lung. Are you gonna put 100 million test tubes?
How you gonna get rid of it?
That's what I'm-
Very good question. I'll get to the intervention shortly. So patient, who are we again therefore monitoring? Because is this easy to treat? No, based on the pathophysiology, the lungs are wet. Okay, so it's impossible to ventilate. So therefore, is it better managed or prevented? Okay, so who are we going to prevent it in? All of these patients here, because these are the acute lung injury patients. Okay. If we can't, then we have to, here we are, the patient's already in ARDS. The only management is what? Let's look here. What does the management say?
Man.
Intubation and mechanical ventilation. We'll explain when we get to,
Intubation.
yeah, after the break. Come back at 2:35.